Thank you very much, Dr. Lee. And I'd like to introduce our next speaker, my friend and colleague, Dr. Shelley Hankins. Dr. Hankins is the medical director of the LVAD program and the heart transplant program at the Drexel University College of Medicine. And Dr. Hankins will be talking about durable VADs, which patients and families are appropriate and what should they expect, understanding the unique patient-machine interface as well as patient responsibilities unique to mechanical cardiovascular support, recognizing the critical role of the family in the success of mechanical cardiovascular support, and identifying and rectifying potential barriers to patient self-management. Dr. Hankins.
All right, thank you, Dr. Lilly, and also thank you for the organizers for having us here today. I'm actually covering for our VAD coordinator, Teresa Rowe, and what I want to cover in this particular talk is really what the patient experience is with LVADs. So unlike most cardiac technology, the patients, it's almost forgettable for them. But with VAD technology, to be successful, the patient and family have to be active participants or else you'll have a disaster. So what I'm going to talk about with this talk is basically who's involved and what the family has to understand before you embark on VAD therapy. And also how we communicate our technical expertise into something the patient can actually understand. So in order for VAD implantation to be successful, it takes a whole team to do it. You need the cardiologist to identify the appropriate patient. You need the surgeon to perform a great operation. But to really make it work, you need nurse coordinators and social workers, family support, community agencies, and also industry resources. So I'm going to go through each one of those components and how critical they are really to making this therapy successful. So if you're a patient and your cardiologist has now said, you know what, you need an LVAD if you want to survive, what can the patient expect to happen? So in the early period, and this is what we do at our center so that patients can transition through this therapy more easily, they meet the VAD team. So those are the people that I showed on the previous slide. And the most important key thing here is that the patient has to identify family support. So like Dr. Isaac was saying, with DT, you have to have support, same as with transplant. And actually, I would say with VAD therapy, your family support is actually very critical because it's your family member who's going to be doing the dressing changes every day. So the patient has to identify a family member and hopefully two so that they can give one of the people a break from time to time. Then the other very key thing is when we approach patients about VAD therapy, we have a very serious and frank discussion about end-of-life issues. Because as you've seen in the previous slides, especially from the rematch trial, there's only a 25% survival for patients who have end-stage heart failure without VAD therapy. So we asked them to consider that. We also asked them to think about, eventually this machine will stop working. And so the family has to be ready or understand the issues of actually turning the machine off. Hopefully, a decade down the line, but it's still something that we like to address up front before the VAD goes in. In terms of the end-of-life discussions, it's actually mandated for us in the US to have a palliative care consult. So they help sort of smooth out these issues and help the patients think about their advanced directives before they even go to the operation. So in terms of pre-VAD education, like I said, the patients have to understand all the technical aspects about the pump. And so we go over pump function, Driveline Care, lifestyle changes, anticoagulation management, which they're now in charge of, and also emergency planning. So every time they leave the house, they have to have certain equipment with them at all times, phone numbers with them at all times, backup gear at all times. So we sort of train them up front about here are the things you're going to need to travel with every day. These are the two continuous flow pumps which you guys have seen earlier. So the HeartMate 2 is currently approved for DT, and the HeartWare is approved for DT and BTT. But these are the two workhorses for us. This setup is very important. So this is how we actually train the patients before the pump ever goes in. So they have videos and booklets, et cetera, of what life is like with an LVAD. But this guy here, this mannequin, is how the patients and their families are trained on how to actually take care of the driveline. So in terms of the technology, what the patient sees every single day is they're tethered to this driveline, which is where their power source is powered. So this is their lifeline right here. And that's how it's explained to them. This is your lifeline, and you have to protect it because if you don't, your pump will stop. So what we have patients and families do before they ever go to surgery, if the patient is capable, because sometimes the patients are very ill and they're not able to learn this, but their family member certainly has to learn how to do sterile dressing changes, and it starts before the pump goes in. The next thing patients always ask us is, what can we expect following VAD surgery? So the surgeon goes over in detail what the operation is like, what they can expect during their post-op period, the expected length of stay after VAD placement. There's also extensive education not only on driveline care, but also mastering care of the pump, which means handling the power sources at all times. There's also an extensive discharge process that we do before patients can ever leave the hospital. And then they want to know about follow-up care and recovery. So just like transplant, there's intensive follow-up that patients have after a VAD is implanted. So this is a busy slide, but we have to explain to the patients exactly what does a continuous flow pump mean. And the big thing that we alert patients to is that, when you are engaged with other healthcare providers, let them know that you're not going to have a pulse. And so that they sort of understand and not get freaked out. We actually had a patient that went to an outside emergency room and they weren't able to get the blood pressure. He was talking to them about his issue. It was a sort of trauma related, but because they didn't get a blood pressure, bells and whistles rolled off and they, transported him over right away to us. But he was talking to them. So he was unable to communicate with them that, they checked my blood pressure a different way, I'm okay. But so that's important to let patients know, so when they show up at outside places, they can tell them, you're not gonna really feel a blood pressure from me or obtain a blood pressure. The other thing patients have to know are the device parameters. So they need to have a concept of what the speed means or the RPMs that you're running the pump, the power, not necessarily a pulsatility index, but also the estimated flow. You may say, well, why does a patient have to know this? Well, when they call us in the office with issues or trouble or shortness of breath or they saw an alarm, these are the parameters that they need to kick off to us, not only what their symptoms are, but hey, what is the pump reading? What's the speed? What's the power? What's the flow? And they also have to be cognizant of, because we ask them to write this down, is this different than your usual speed? Is the power changed? So these are the parameters that we ask patients to pay attention to, and they log it just like they log their blood pressures. In terms of equipment, so this is what patients actually go home with, and this is the peripheral equipment for the HeartMate 2. They have a power module, they have a backup cable, so there's a cable that I showed you that's attached to them internally, but they also have to have backup cables unless something cracks. They have a multitude of batteries. I think they go home with about 12 battery clips and this universal charger, which we ask people to actually carry around with them if they're going to be away from home for an extended period of time, because you can keep, charged batteries. They also have this travel bag, so you can tell a VAD patient you can't hear the pump, but they'll always have their bag with them, because this is where they're supposed to keep all their peripheral equipment. This is the peripheral equipment that you see patients with the HeartWare device carry. So it's pretty similar. They have batteries, battery clips, and extra plugs with them at all times. In terms of how you power the pump, so this is the controller, the cables, and the cables are connected to these batteries. So patients have to be able to have this equipment with them at all times, and they have to know how to change their batteries and when to change their batteries. And believe it or not, you can imagine, if you're somebody who we tell you this is your lifeline and you can never be disconnected from batteries, we spend a long time with the patient and their family members on how to actually safely change out these batteries. And it's important to have a family member that can do it, because a lot of times if the patient is in trouble, and the bells and whistles are going off, you have to have somebody with a level head who knows how to change batteries or to connect them back to a wall unit for power supply. So this is sort of a drill we go through every single day with the patient after the pump goes in, and even ideally before the pump goes in, so you can start having people get comfortable with how you make battery changes. This is just a similar, but it's a different configuration for the HeartWare device, but it's the same concept. In terms of connecting your battery. So you can never be disconnected from a power source with an LVAD. You either have to be on battery or AC. This is the pocket controller. So this is what actually runs the pump. And so this is always connected to the patient, because this is what actually it's the computer that drives the pump. And so patients have to be aware of this screen, this diagnostic screen. So if an alarm happens, they're able to call us right away and say, hey, I'm seeing a red alarm, a yellow alarm, etc. They have to pay attention to this. This is how much life is still in the battery. And they have to be very cognizant of these connections here to make sure that the pump is securely connected to the power, to the pocket controller. So this seems scary, but if you introduce patients to these things before the pump goes in and to their family members, it brings down a lot of anxiety. This is what the controller looks like for the HeartWare, the other device. And as I pointed out to you before, patients have to pay attention to these numbers. So they don't have to memorize them, but you want them to sort of know what their baseline is. So for instance, this is the power. On this one, it's 4.5 watts. So if they notice that this power is going up and up and up, that can be an indication that the pump actually has a thrombus. So you want them to just generally pay attention to what their numbers are. And if they call you about a symptom, they should be able to recite what these levels are so that you can help troubleshoot. This is what the Driveline looks like. And so our coordinators, when they're explaining to the patients, they call this is your lifeline. And so what you're seeing here is basically just betadine around it. But so this is actually a clean Driveline. So this is what the patient looks at and sees every day. And this is what we spend a lot of time, in addition to learning how to change batteries, a lot of time is spent on learning how to take care of this Driveline site. So in terms of Driveline care, it's always done with sterile technique. And this has to be done usually by a family member because, remember, it's here, it's because of the position on it and the patients are laying flat, they can't see to do this dressing change. So a family member has to be proficient in doing this, and hopefully 2 family members, because sometimes people want to have a break. We've had some odd situations where the family member is not available or something happened, and so patients can put a mirror in front of them and do it that way, but it's very awkward. So this is why it's really a 2-person job to have an LVAD put in. The other thing that they have to do with the Driveline is, in addition to the dressing change, is they have to inspect the coating of the Driveline, because sometimes there are cracks and tears in the actual coating. And if that happens, all we do is we have something called rescue tape. And they simply just tape it up so that you can prevent the Driveline from having a catastrophic rupture. Also, in terms of their Driveline, patients are advised on what to look for in terms of signs of infection. So the first one I showed you was clean, but this shows you what an early skin infection looks like progressing to more severe. So again, the patient and their caretaker, when they're doing their dressing changes, just have to pay attention to what the character of the Driveline site looks like. Anticoagulation, so with the continuous flow pumps, Coumadin is mandatory. And like you guys heard before, the goal INR is between 2 and 3. So what we do at our center is patients go home with a INR machine and a Lear monitor, and with that, we're asking to check their INRs usually once a week for a while, and then every 2 weeks once things are stable. But again, with doing that, patients have to understand what Coumadin is, what dietary restrictions they have to have, and what those numbers mean, because when they check their INR at home, they're the first ones to see the number. So if they see something very high, we ask them to call us immediately right away. Otherwise, they can wait for us to call back and give further Coumadin instructions. So again, it takes very active participation from the patient to be successful with an LVAD. And then there are lifestyle changes. So you can imagine if you have a cord coming out of your abdomen, that may cause you some concern. And for some patients, it makes them very anxious that that's there. There's certain activities that they can't engage in, contact sports. They can never swim. They can't take a bath. Patients can shower. They have something called a shower kit, which is basically plastic that they wrap around their abdomen so that they can shower. Believe it or not, early on with the first generation LVADs, we told them never to shower. But that's changed now that we have these shower kits. Then the next thing is travel. So patients say, well, if I have this, am I really allowed to take vacations or go anywhere? And the answer to that is yes, as long as you have your battery packs, et cetera. And we've had our first excursion with the patient was from Philadelphia to Bermuda. So that's an island sort of off the coast of the US. We also had a patient who went from Philadelphia to India. He had a house in the Himalayas, and that all worked out fine. So if your patient is well trained and careful, they can travel. Emergency planning, so that's another very key thing. So before we discharge patients from our center, our coordinators are in contact with their local EMS and sometimes their local firehouses, just so that they know that, hey, you have an LVAD patient in your catchment area. And that way, there's nothing special that they have to do except to just be aware that this person, when you see them, needs to be immediately connected to a power source. We've had patients who have blacked out at home. Her husband panicked and could not remember how to hook up batteries, so as soon as EMS got there, they were able to put her right back on her power source. So We train EMS that you have a VAD patient in the area. We let them know that, hey, this person's not going to have a blood pressure that you can check in a normal way, so that they understand that. And if we discharge patients to a rehab center, for instance, our coordinators will go there and also train the staff on how to take care of these patients while they're under their care. And so discharge planning. So I've gone over all of the things that patients and family have to understand before they leave. And believe it or not, we make them take a test. They have to take a proficiency test before the patient is discharged after their VAD implant. So they have to demonstrate that they can change batteries, that they can troubleshoot alarms, that they know how to change the driveline dressing, and that they know and understand how to monitor their INRs with the home INR kit. So there's a lot that they have to do. And we have a series of checklists in terms of following up the EMS, going through all discharge proficiency, physical therapy, limitations that they can and cannot do. And because there's so many details to remember, what I would suggest for any center is to use a checklist system so that you make sure you hit everything in every patient. In terms of follow-up as an outpatient, we initially see them once a week. And that goes on until we're clear that the driveline site has totally healed. And then what everyone likes to hear from a patient perspective is that they can go from changing their dressing every day to now changing it to once a week. And that really makes life much easier for them. And then, of course, after they wake up and realize that they're at home with this pump, you can imagine a lot of questions continue. So almost with every visit, there's ongoing education so that people become more comfortable with the device that they have. And the final thing, which I should have put on here, is that when you start as a VAD center, you have to always have someone on call. If you have a situation where you let house staff take your calls, et cetera, that won't work with a VAD patient because a lot of times time is of the essence. So like I said, the patient that we had that collapsed right there in front of her husband, he knew to call the VAD coordinator, and the VAD coordinator called 911. Because he was just so freaked out about what was going on, even though we would have told him to call EMS first. But she was able to, she heard the alarm blaring, she called the ambulance, and when the ambulance came there, was able to instruct them on how to hook the patient back up to the power source. So you need to always have someone available at a moment's notice, at least by phone, to help these patients. The other thing is sometimes it comes up is that patients have to change their controller, which can also be scary if it's not done properly. So we're able to instruct them over the phone how to change it, and it always goes smoothly, but you need someone who's experienced on the other end of the phone to sort of walk them through what to do. And so even with all of the things that are involved with actually taking care of a VAD, patients actually do go back to an active lifestyle. And most people, let's say the vast majority of VAD patients, are actually happy after they've gone through the surgery. And with that, I'll take any questions. What are we doing?